Welcome, everyone. Happy Friday. Looking forward to three really nice presentations from within our division. And we're starting with Dr. Anna Zemke. And I'll let you take it away.
All right, thank you. So today for my talk, I am gonna be discussing kidney health in American Indian and Alaska Native populations. Overview of, so overview of my talk today, I would like to discuss some well-described health disparities in the American Indian and Alaska Native populations, look at the history of Indian health services and different care models for AI and AN individuals, the Indian Health Services Kidney Program, and their effort to address kidney disease, and then also a review of some nephrology-related studies and next challenges to tackle. So looking at kidney disease burden, it's predominantly diabetic kidney disease. And if you look at USRDS data in 2015, 69% of incident ESRD cases were attributed to diabetes in American Indian and Alaska Native populations, compared to 44% in the overall US population. Disparities in incident rates of ESRD have somewhat diminished over the past 20 years. But in the most recent USRDS data, so from 2021, they're still 2.1 times greater than non-Hispanic white populations. And in looking at all this data, it's important to consider that there are large regional variations in care and outcomes. And transplant outcomes in terms of graft and patient survival are comparable to the overall US population, but AI and ESRD patients are less likely to be placed on transplant waiting lists and have longer wait list time than the general overall population. So here, just a pictorial version of some of that. Here, the blue line is the American Indian or Native American group. So this is ESRD incidence data. Looking at dialysis modality type at incident ESRD, so in Native American patients, we see that individuals are more likely to start in-center hemodialysis and less likely to have a preemptive transplant, which is that green bar. And these disparities persist throughout. So now moving to prevalent ESRD cases, they persist and grow over time, again, with more individuals remaining on in-center hemodialysis and less getting transplants. So as we think about these, we know kidney disease doesn't exist in a vacuum, and American Indian and Alaska Native individuals are facing challenges in many other areas of their lives. So we know health expectancy is lower than the general US population, 21% living below the poverty line, unemployment is higher, there are higher rates of food insecurity, and then there is a long history of forced relocation and structural discrimination. So, as we look at all these challenges and disparities, I'd like to take a step back to consider the unique responsibility that the US federal government has to American Indian and Alaska Native individuals. And this really dates back to the US Constitution and initial treaties with American Indian tribes promising health services. And so this was subsequently codified through acts and declarations by the federal government. As we move forward 2 centuries, much has changed. And by 1975, there were 1.2 million American Indian and Alaska Native individuals living within the United States. And the population had shifted, about roughly half living on reservations and half living in more urban areas. So This act in 1975, it remedied a lack of federal care for serving American Indian and Alaska Native individuals that were living in urban areas. So until that time, they had been largely cut off from these services. So establishing outreach programs, and then also as part of this act was allowing IHS to be able to collect and maintain other insurance payments through Medicare, Medicaid, and private insurance when they provided eligible clients care in their facilities. So looking at health service options, so we've discussed the IHS. It is a comprehensive health delivery system. So they have hospitals and care clinics, and it serves about 2.5 million of the nation's estimated 5.2 million American Indians and Alaska Natives. For American Indians and Alaska Natives living on reservations, it is the predominant care provider. Also, we see care in urban centers. And the services can be provided directly or through tribal contracted health or tribally operated health programs. And then individuals can also use private insurance that they've purchased or through jobs, and Medicare and Medicaid benefits as well. So funding of the IHS is often brought up as inadequate, which is complicated to delve through because many individuals are eligible for other health benefits. But given the task that IHS has taken on and this federal promise to provide healthcare, I think we can argue that it's not an excessive budget by any means. And so looking at this graph on the left, so national health expenditure in US dollars is about $10,000 per capita or per person is the average amount spent on healthcare. When we look at other federally provided programs like Medicaid, the number is just over 8,000, same to federal prison populations, and Medicare is about 13,000. Indian health services per user is about $4,000, so much lagging behind that. So in talking about, constraints of a health system and challenges facing this community, I wanted to delve into some of what's been done in terms of kidney health. So the IHS had established a kidney program in 1989, and its intent was really to enhance existing diabetes care and to provide better CKD care within the primary care model. And in this population, so when we look at end-stage kidney disease patients, comorbid diabetes is a rate of 79%. So again, kind of mirroring the cause of ESRD overall, and making the bundle of diabetes care and kidney disease care in general very impactful. So looking a bit what this program entailed. So, filtering into primary care, this idea of providing increased educational resources, not just for the specialists, but for primary care and local providers through electronic medical record support and templates, checking albumin creatinine ratios in all diabetic patients, lumping in anemia and bone disease care into diabetes care as well. And so, this program has been running for several years, and as new data comes, it continues to be updated. And, in this time, there have also been ongoing studies and improvements in diabetes care that are based on American Indian populations as well that I wanted to discuss. So looking a bit more at, research studies that have been done. So one of the largest studies is looking at diabetes in Pima Indian tribes. And this study was run from 1965 to 2007, and it in this tribe, there are extremely high rates of diabetes. Over 1/2 of those greater than 35 years old had type 2 diabetes. And so in this cohort, nearly all the end-stage kidney disease encountered was attributable to diabetes. And so throughout this time, with close follow-up, there was a nice review article published that was just looking at the different contributions of many findings that came out through this research. And so studies looking at how albumin measurements can be used in clinical practice, looking at modifiable risk factors, looking at glomerular hemodynamic changes that precede clinically detected CKD. And, this study provided a lot of information for this population, but also just for diabetic kidney disease, as we're seeing increasing rates of diabetes worldwide. So looking at a few other studies that have been done. So the Strong Heart study it's a cardiovascular risk study looking at American Indians. So this was done in over 26,000 participants. It started in 1984 and is now in phase 7. So there are many iterations and data that has come out of this as well. A lot is descriptive data, again, which is showing us high rates of cardiovascular disease in American Indians. And there were studies in this looking at albuminuria levels, predicting cardiovascular disease less than traditional cutoffs. So then American Indian in the chronic renal cohort insufficiency study, there was published in, I think, 2020, some data a protocol to expand the CRIC cohort to 3 sites in the Southwest to be able to include American Indians following the similar protocol for kidney and cardiovascular outcomes and measurements, with the goal to be able to compare these findings in the American Indian population to other racial groups. Let's see. So there are also many other smaller studies, often in smaller groups of patients and individuals, but I tried to limit this because it is a very broad topic to the broader studies. But I think it's important to note that there are very many studies in looking at transplant access, at looking at how trauma has affected American Indians and Alaska Natives seeking care, and a lot of descriptive work done too on how individuals interact with the health system. So this is, again, looking at larger data, so Medicare data in a larger population, Medicare population using the CHAPS survey. So it compared patient-reported experiences on subjects getting care, quickly getting care, how doctors communicate, and consistently across the board, American Indians and Alaska Native, especially single race American Indian Alaska Natives, reported worse experiences across all these domains. So, challenges to addressing the individual care needs in AI and individuals. So a lot of what we had discussed about care is obtained through multiple health systems, making it hard to track all individuals. There's also a lot of data on, especially outside of the Indian Health Services, misclassification of race, which in a relatively small population, about 1.7% of the total US population, makes looking at trends difficult. Also, different funding resources makes improving care difficult. We looked at the IHS kidney program, and there's been evidence, at least over that same time period, there's been a decrease in the rate of incidence of end-stage kidney disease related to diabetes in American Indian populations. But there are many individuals that do not get their care through the Indian Health Services. So how is their kidney health doing within other health systems? We also discussed fairly minimal funding for the large tasks that the Indian Health Services takes on. It takes on more than just acting as an insurance, but it maintains facilities. It pays for water treatment plants. And so it has a lot outside of just, paying for a physician visit. And then another challenge within the IHS is there are constant unfilled provider care positions, often up to about 25% vacancy and high turnover. And this in part is likely due, their rural locations, and again, underfunding can contribute to that as well. And so populations as a whole, we know that being further from care centers is harder on patients, and especially getting specialty care like transplant care more difficult. And then, there are more studies looking into mistrust of classic health systems and how to work within communities to provide appropriate care. And so all of these, I think, directly relate to challenges in terms of patient care, but also extend into the research realm as we try to look on systems and larger scale levels as well. So these are some of my references, and thank you. And I talked a lot faster than I thought I would. So questions or comments, I am happy to.
Thank you, Anna. Looks like Linda has a question.
Yeah.
And that was a very interesting presentation. I had a question that related to how well doctors communicate. It was under the category of experience care disparities. Could you elaborate a little bit on what that means, and if there are any ideas about what doctors can do to improve their communications? Because that comes up a lot when we look at data related to Black patients, and it would be interesting to see if there's a correlation in the American industry, in the Indian Alaska Native population, and if so, is it a general problem that we just need to fix? Sorry, long question.
Yeah, no, that's good. So I'm sure there are more specifics. I think I didn't go into as much of that research at a provider level. I think a lot of it, more what I had read about, was a little bit more on a systems level. But again, looking at actually navigating a different health system, and often when patients, even if they live in rural lands or rural areas and through the Indian Health Services, they can be referred to care to other. So that's how they can see someone, a University of Washington nephrologist, they'll see transplant at major centers. And so I think that jump in health system is very hard to navigate if it's a completely different health system from where you're getting your primary care as well.
Thank you.
Yeah.
I'm curious if you know anything more about the Indian Health Service, because it sort of reminds me of VA in that it's, or I wonder if it's similar to VA in that VA is something is a system that's kind of tailored to its population, and makes efforts to set up structures, integrate care, and things that are especially important for vets. Anything you know about Indian Health Services, maybe in terms of how they try to address some of the challenges that you mentioned or
Yeah, I think so. A lot of it, I think the kidney program integrating through diabetes care is one example. And I think a large portion of, especially on with individuals living in reservations and health centers on reservations, is keeping as much care there as possible. And I think the goal of bringing more people in, which is again limited by actually getting staffing there. They've also, looked at bringing in, funding to help with scholarships for American Indian, Alaska Native, like health professions students as well, with the thought in a lot of the tribal clinics. I think there's like 11% at least are Native heritage, whereas, in the general medical system, the percentage is much less. And so there is a strong line of people staying in communities that they know well and helping. And so I think that is one of the goals too. And, they have dialysis units within, and I am not exactly sure how that is all funded as well. But I think kind of the goal has been the least amount of transfer of medical care as possible, but still being good care,
Mm-hmm. Mm-hmm.
And hey, Anna, it's Justin. And I love this. I guess I wanted to know, I know you're doing many projects and working on a lot of things, but I guess I want to know if you have any like insights from the things that you've been working on or thinking about that that you didn't talk about in the slide. I don't know anything. Yeah.
Well, so I would say I definitely do not feel like I'm an expert on any topic in here. And I went really fast, but I originally had at least twice as many slides, because I feel like there's so many routes to go down. I think at the end of the day, in terms of from my reading, which is, but again, by no means an expert in this subject, really a lot of it at the end of the day, I felt like focused on providing direct, good care of things we already know, that we can make improvements on, and finding out how to bring health systems into the American Indian and Alaska Native communities, or better ways or culturally appropriate ways, and easier financial ways, easier travel-wise ways to integrate that care. And so I think there's a mismatch there that is going to be challenging. And but one of the things that I thought was so interesting about this topic as well is just this federal responsibility, going back the history of this. And so again, it's one of these, it gets, I think funding is should be more guaranteed in that sense. And I also think funding is interesting from IHS. Again, it is, I guess, kind of like the Veteran Center, in that you look at the cost for the whole person over their lifetime, instead of how a lot of our health systems, at the how we bill private insurance, we're billing per clinic visits. And so sending someone to a referral is potentially good for the health system as a whole. Whereas in, a system with like the Indian Health Service, they really, as part of this kidney health program, we're trying to say like, this is part of primary care's responsibility now. So whether they needed more responsibility or not is another question. But I think that is an an interesting thing in this population and this funding structure.
Yoshio.
Thank you, Anna. Yeah, I think just a quick comment though, if you look at the Indian Health Services, I mean, they've done a really remarkable job if you think about it on a population scale. You're looking at a reduction of 350 cases per million population over the course of just like 30 years. And to me, that's like actually quite a remarkable impact at the population level in terms of lowering or reducing the end-stage kidney disease incidence. And so to me, there's probably a lot that we can actually learn from IHS, particularly in terms of implementing kind of evidence-based practices. It will be interesting kind of projecting forward as more and more, therapeutics sort of come online to slow the progression of, diabetic kidney disease, for example. But I think, as of right now, I think the Indian Health Services probably has been the most successful example of any single health system or program in terms of reducing the incidence of end-stage kidney disease, at least in the United States.
Yeah, I'm increasingly interested about Indian Health. I'm gonna have to read more about this. A comment from Sarah Doty about how they've managed to incorporate specialty care and tailor to their population. Really interesting. Well, thank you, Anna. Thank you for that talk.